Hey guys, welcome back once again to my channel. So today we are going to study how to take case histories. Okay, so here we have a case scenario. Patricia Garrison, this is the name of our patient. Okay, she is a 36-year-old female, comes to the office complaining of not having the menstrual periods recently. Okay, so she is concerned about it, and that's why she has came to you. Now we took her vital signs. So first of all, we took her blood pressure. It came out to be normal, 120 by 85, it's normal. Temperature, well, temperature is 98 degree Fahrenheit. Heart rate is 65 per minute, beats per minute, and it's regular. Building the doctor-patient relationship. He will just going on to take on these boxes. Okay, first, examinee knocked on the door before entering. Examinee, examinee is the student, okay, who's coming. Whether he knocked on the door. The first thing is you should knock on the door whether patient is admitted or he's like whenever a patient gets admitted he would be allotted a room. Okay, do not enter inside the room directly. Okay, first knock on the door. Knock on the door before entering. Examiner introduced self himself. Okay, so like we are just cross checking whether the file which you have got from the nurse, the vitals which we have got, these vitals are of the patient whom we have come to examine. Examinee made eye contact with the SP. SP is nothing but the patient. So you should make a eye contact with your patient. That's also important. Now in this case, like the teacher is your patient. Like he's just disguised as a patient. So he's just checking whether you are confident enough to ask uh, okay as a doctor. These are the five main points. Next, reflective listening you would be checking. Examiner asks an open-ended question and actively listen to the response. It's not like you should just cut the statement of the patient. Let him explain everything. Let him explain what problems he's suffering from, and let him tell each and every problem why or she has come to the hospital. Examiner asked the SP to list his or her concerns and listed to the response without interrupting. Examiner summarized the SP's concern, often using the SP's own words. We should explain the patient in his or her own language. Okay, in whichever language they could understand at what the patient has really got or is suffering from. Information gathering. Examiner elicited data efficiently and accurately. Questions. Chief complaint, patient's response, I haven't had a period in 3 months. Question, menstrual history. I used to have regular periods every month lasting for like 4 to 5 days, but over the past year I started having them less frequently. Every 5 to 6 weeks lasting for 7 days. Pads or tampons changed a day. Okay, you should ask about pads or tampons whether the patient is using pads or tampons. So the patient would answer like it was 2 to 3 a day, but the blood flow is becoming less, and I use only one a day. Like now the menstrual bleeding is being reduced, no? So her tampon use would also be less. Okay, so she's saying that first she used to use 2 to 3 tampons per day to control the bleeding. Okay, but right now she is using only one. So it's also suggesting that yeah, really the uh, amount of bleeding or the menstruation is been reduced. Age at menarche. So age, like at what age the menarche started, the first time the bleeding started. So age of menarche is age 14. It's quite normal. Then we should ask about weight changes. There can be any sudden loss in weight, like 1 to 2 kgs. So she said that I have gained 15 pounds over the past year. Patient is saying cold intolerance. Sometimes a person starts feeling cold unnecessarily, even if the environment is warm enough. It's quite normal. It's not cold weather. The patient starts feeling cold. Okay, so cold intolerance, no. Skin or hair changes, any kind of rash or any kind of purpuras or any unusual thing whether the patient has noticed in recent days on her skin. Okay, it can be anywhere in the body. So actually I recently noticed some hair on my chin. Now that's a good point. Now the thing which is required for like growing the hairs is the main thing. The main hormone is the testosterone. Okay, and it's usually mostly found in males. So she recently noticed some hair on her chin and have been plucking it. Okay, voice changes. Now that's the major thing. Voice changes, no. Change in bowel habits, no. Appetite changes. Any changes in her daily routine of appetite, whatever she's eating, whether she's feeling to eat or not. Okay, so I have a good appetite, she's saying. Fatty diet or any kind of diet pills she is taking. So no, I have been a vegetarian for the last 10 years. Fatigue, no. Depression, anxiety, stress, no. Hot flashes, no. Vaginal dryness, itching, no. Sleeping problems, falling asleep, staying asleep, early waking, snoring, no. Urinary frequency, we should ask. So it's also no problem in it. So no. Nipple discharge, well, yes. Just last week I noticed some milky discharge from my left breast. Well, this is another concerning point. Like she's not pregnant, and then also she's having some kind of discharge. Now it is milky in nature, so maybe, okay, so maybe there is lactation due to some kind of hormonal disturbances. Visual changes, no. Headache, no. Abdominal pain, no. Sexual activity once a week on average with my husband. So that's the point. What would have been happened in this case? Maybe she's pregnant, because in pregnancy menstruation, like, it stops. Okay, she can get pregnant until and unless you don't cross the menopause. Okay, there's possibility of getting pregnant. Contraceptives, does she use contraceptives? So she says the same pills for last 8 years. Pregnancies, I have one child, he's 10 years old. Problems during pregnancy or delivery, no, it was a normal delivery and my child is healthy. Miscarriages or abortions, no. Last pap smear was done 10 months ago, it was normal. So pap smear also done, it is normal, but it wasn't 10 months ago. And maybe there's a possibility, because she can be pregnant. Okay, 10 months is a long time. We just need 9 months for a baby to develop. Okay, so history of abnormal pap smear, no. Current medications, none. Past medical history, none. Past surgical history, none. Family history, my father and mother are healthy. My mother began menopause at 55. So here there is a one history that her mother had a late menopause. Okay, but in this case she is getting early, so that's totally different. Occupation, she's a nurse. Alcohol use, none. Illicit drug use, never. Tobacco, no. Exercise, iron 2 miles 3 times a week. Drug allergies, no. So these all many questions you should ask your patient, especially the female patients. Okay, now physical examination we are doing. Okay, that those were just verbal questions. Now physical examination. Examining washed his or her hands. Before examining our patient, we must wash our hands. Examining asks permission to start the exam. Ask your patient that I am going to now do some physical examination, I am going to do palpation, so permission you should take first. Examining use respectful draping. Okay, just that part uh, which need to be examined, that part should be exposed. Apart from that, all the other parts should get draped. Okay, examine did not repeat painful maneuvers. Okay, if in case she's like got any kind of painful stimulus while palpation, don't repeat it again. Okay, because she's getting pain. Exam component and manual. Okay, so neck examination is the first. We are checking for thyroid. Okay, examining thyroid gland. Second, your CV or the cardiovascular exam. By using stethoscope, we are doing auscultation on various points. Pulmonary exam, again auscultation, backside. Extremities inspection. Neurological examination, like visual fields, extraocular movements, and check the DTRs. Closure. Now, examine discussed initial diagnostic impressions. Now, one diagnostic impression does come inside our mind after doing everything. Like we did verbal examination and we also did physical examination. Now, examiner discussed initial management plans. So he has come to a differential diagnosis he has made, and he has come to a final diagnosis. But for that, he need a confirmation. Okay, so for that he would advise some more investigations. So here he would explain all this stuff. Okay. So follow-up tests. Examiner mentioned the need for pelvic and breast exams. Okay. Here in this case, two main exams are required: pelvic, because menstruation is not happening, and breast exam for the nipple discharge. Okay. Examiner asked if the patient had any other questions or concerns. That's the last thing you should ask. Any other problem do you have? Okay. Don't ask this question like very early. Okay. It would just stop everything. So, sample closure. Mrs. Garrison, there are few reasons you may not be having regular periods. Now, I don't know whether you are able to see or not. Okay, now it's fine. Okay. Mrs. Garrison, there are few reasons you may not be having regular periods. The first thing we need to do is determine whether you are pregnant. We can do that with a simple urine test. The other thing we need to do is conduct breast and pelvic exams, especially since you have some nipple discharge, and look for any signs of menopause. Now, menopause is highly unlikely at this age. Okay, she's just 36 year old, but on rare occasions it may occur. A blood test, I do have this. Okay, a blood test to measure your hormone levels will also help us determine you whether you are menopausal or any hormonal imbalances been occurring inside your body. This will give us a good start in figuring out why you haven't had your period, and we will go from there. Do you have any questions for me? So, this is how you get the paper on which you need to write everything. Okay, so you need to write history, you need to write the age of patient and family history, medical history, every single thing. Then we do the physical exam, and what did we notice in our physical exam, that thing you should write here. Then we should go on to our differential diagnosis, the first differential diagnosis, the second differential diagnosis. Differential diagnosis is nothing but that what all possible reasons can be there for the patient not having the, like in this case she's not getting periods. Okay, so what are all are the reasons, what can be the reason, all that should be written here. So history finding, physical exam, history finding, physical exam. Okay, then your diagnostic workup, your CBC, your urine test, your LFT, RFT, whatever you have advised. Now, okay, now a 36-year-old female complains of amenorrhea for last 3 months. She recently noticed some milky discharge from her left breast, as well as abnormal facial hair, but denies visual changes and headache. Now, why visual changes and headache they have mentioned? Very important thing. There can be a problem in pituitary, any kind of pituitary edema, adenoma, cancer of pituitary. Okay, it can compress onto your optic nerve and it can cause visual disturbances. So she's not having any kind of visual disturbances. We can rule out one thing, that there is no problem in pituitary. Okay, as well as headache. So she also describes oligomenorrhea. Oligomenorrhea is like very less blood during the periods. Hypomenorrhea and a 15 lb weight gain. Okay, there's a weight gain over the past year, but denies dry skin, cold intolerance, voice change, constipation, depression, fatigue, any kind of sleep problems. These things she's not having. Okay, she's denying all this. She also denies hot flashes or any kind of vaginal dryness or itching. So there's no problem in vaginal like outflow. Okay, so there's no fever, there is no any kind of infection. Okay, that we would get like when we are going to do the urine test, right? In the urine test we would find like what all stuff can be there. Now next, this was history given to us, and now obs gynae history. First thing, menarche at age 14. For the past year, menses have been cycled every 5 to 6 weeks and lasted for 7 days with decreased blood flow. Before that, menses cycled every 4 weeks. G1, P1, gestation 1, pasteurization 1. Okay, she is pregnant only for once and she is having one kid. Okay, no abortion. Okay, one uncomplicated vaginal delivery 10 days ago. Uncomplicated means not complicated. Okay, last pap smears was done 10 months ago. No history of abnormal pap smear. Sexually active with husband once a week on an average. Uses OCPs for contraception. All these things you need to write. Okay, in this way. Now, ROS negative except as above. Allergies, no allergies. Medications, no, she's not on denies any kind of tobacco, any kind of alcohol, or any kind of drug usage. Exercises regularly. Vegetarian, hasn't changed her diet recently. Mother had menopause at age 55. In neck, there is no any kind of thyroid problem, so no thyromegaly, means there's no increase in thyroid size. Chest, clear breath sounds bilaterally. In heart, triple R, normal as soon as 2. No murmurs, no rubs, no gallops. In abdomen, abdomen is soft, non-tender, non-distended. So first differential diagnosis which comes to our mind is that she is pregnant. Why? Because the history suggests that she is pregnant. First thing, change in menstrual cycle. Second thing, regular sexual activity. Third thing, previous successful pregnancy. Differential diagnosis number two, hyperprolactinemia. Maybe the prolactin in her body is more because she said that there is milky discharge. Now we all know milky discharge is lactation is due to prolactin. So maybe there is high amount of prolactin secretion. That's why she's not getting any periods and that's why she's getting milky discharge. So there's galactorrhea, means the milky discharge coming out from her breast, and she's having oligomenorrhea. That is pointing towards hyperprolactinemia. But it is we can't go directly to the conclusion, right? We need some tests. Differential diagnosis number three. Now this is very interesting. Polycystic ovarian syndrome. Now in this, what happens? There are like cysts formation inside the ovary. Okay. So polycystic ovarian syndrome. Why we are saying? Because there is weight gain. First thing. Second thing, there is hirsutism, hairs on her, she told, chin, and oligomenorrhea. So these three complaints are pointing towards PCOS, polycystic ovarian syndrome. Okay, now what all workup we need? We first of all need to check her urine, so urine HCG. Then we are going to check pelvic exam. Why? For PCOS. And then we are going to check her breast for milky discharge. And we are going to check her prolactin levels. We are going to check her thyroid stimulating hormone levels. Then we are going to check her luteinizing hormone, follicle stimulating hormone. So these all workups we need. Now, case discussion. Patient no differential diagnosis. First of all, pregnancy. Although this patient's symptoms suggest a hormonal cause of oligomenorrhea, any change in the menstrual cycle warrants consideration of pregnancy. Pregnancy is the most common cause of secondary amenorrhea in women of childbearing age and should be ruled out during the initial evaluation. Mensuration may not be necessarily ceased completely during the pregnancy. Coming on to the next differential diagnosis, which is hyperprolactinemia. This causes menstrual cycle disturbances, galactorrhea, infertility. It may result from variety of conditions including your pregnancy, pituitary lesions, hypothyroidism, renal failure, and cirrhosis. Should I explain? You all know, right? What is cirrhosis? What is renal failure? What is hypothyroidism? Or it can be the side effects of the medication. But we know that she told us that she is not on any kind of medications. We are just ruling all those stuff out. Roughly 70% of women with secondary amenorrhea and galactorrhea will have hyperprolactinemia. Coming on to the PCOS, polycystic ovarian syndrome, it manifests with first of all hirsutism, secondly obesity, weight gain, virilization, infertility, glucose intolerance. About half patients have one half patients have amenorrhea due to chronic anovulation. The patient's oligomenorrhea and hirsutism in this text with recent weight gain suggests the diagnosis. Additional differential diagnosis apart from these three can be like thyroid disease. So both hyper and hypothyroidism can cause your menstrual irregularities. Although amenorrhea is more common due to hypothyroidism, Except for galactorrhea and weight gain, the patient does not have other signs or symptoms of thyroid disease. Okay, we checked her thyroid in the physical exam, it was normal. Premature ovarian failure. This refers to the primary hypogonadism that occurs before the age of 40, but her age is 36. That's why we just ruled it out. So, premature ovarian failure, this refers to the primary hypogonadism, decreased function of the gonads. Gonads in this case are the ovaries. So, decreased function of the ovaries. Okay, but it occurs before the age of 40. Okay, before the age of 40, it's written. So, 36 is the age. So, yeah, there is a possibility of having premature ovarian failure. Causes include like autoimmunity. Your immune cells are attacking our own body cells. Okay, so that can cause attacking against the ovary. They are acting. Pelvic radiation therapy, chemotherapy, surgical bilateral oophorectomy. Surgical bilateral oophorectomy. Through surgery, we have just removed both the ovaries. Okay, so oophorectomy. And the familial factors. The patient's lack of menopausal symptoms like fatigue, insomnia, headache, diminished libido, depression, and hot flashes makes the diagnosis unlikely. Like lack of lack means there is absence. Okay, absence of these like these things like fatigue, insomnia, headache. She's not having any kind of this. Asherman syndrome. I love this word. Asherman syndrome. This describes the amenorrhea due to endometrial scarring. What happens? Uh, Mostly in cesarean sections or any kind of surgery, there are adhesions occurring between the layers. Okay, so those are also referred to as scarring. Okay, so endometrial scarring can cause amenorrhea, which can occur following uterine infections. Infections can also lead to Asherman syndrome. It's not like only surgeries lead to it. uh, Vaginal estrogen effect is normal here in this case, no problem with that. Diagnostic workup. Now we advised our patient to do what first? Urine test. So urine, we are going to check what? HCG, to rule out the pregnancy. Urine HCG. If urine HCG present, she is pregnant. If not, then she is not pregnant. Pelvic and breast exams. So required to check the genital virilization, which is clitoromegaly. Clitoromegaly, you all know what is clitoris, right? That we all have, like males have penis. So just homologous to penis, there's clitoris inside, like in the female. Okay, so clitoris gets enlarged. So it's like clitoromegaly. The word has been divided into two parts. Okay, clitoromegaly. So if that is seen, clitoromegaly, then it is suggestive of genital virilization, uterine or adnexal enlargement, estrogen effects. Via inspection of vaginal mucosa, we can say that maybe estrogen is acting, and to elicit breast discharge. Okay, so we are doing two exams, pelvic and breast exams. Why we are doing? To check these stuff. Prolactin and TSH levels we can check. So to screen the hyperprolactinemia, break this word, high prolactinemia, and thyroid disease. FT4 is also useful in hyperthyroidism. So T3, T4 levels, but here T4 levels are also useful in hyperthyroidism or central hypothyroidism is suspected. Central means central. Through the pituitary, the messages are coming. TSH is coming and telling the thyroid, please secrete the thyroid hormone. So maybe this problem, this excess of messages coming, and excess of message like excess of TSH is coming, or TRSH, thyroid releasing hormone is coming, and that would cause the thyroid to function more and more, but it's not in this case. Next, luteinizing hormone and follicle stimulating hormone, PCOS, polycystic ovarian syndrome. Now it is a clinical diagnosis. An increased luteinizing hormone FSH ratio would be seen, but it is neither necessary nor sufficient to make the diagnosis. Physiologically, increased levels of estrogen, okay, derived from the obesity are believed to be suppressing the pituitary follicle stimulating hormone, leading to a relative increase in the luteinizing hormone. Constant luteinizing hormone stimulation of the ovary then results in the anovulation, means the uh, every month ovum gets released. Okay, so that would not occur, anovulation, and therefore amenorrhea. And elevated FSH, which is greater than 40 international units per milliliter, is diagnostic for premature ovarian failure. Electrolytes, your blood urea nitrogen or creatinine, glucose, AST, ALT, bilirubin, alkaline phosphatase. So many tests. Okay, AST, ALT for liver, alkaline phosphatase again liver, bilirubin liver and gallbladder, glucose for your pancreas, burn and creatinine for your kidneys, and electrolytes, of course, very important to check. So to check renal and hepatic function, we need to do all these tests. Screen for evidence of hypercortisolism, like high sodium and low potassium would be seen. If seen, then it is suggestive of hypercortisol. Okay. Hmm. Testosterone, DHEAS, to screen the androgenism. Androgens, we all know testosterone. When amenorrhea is accompanied by hirsutism and virilization, then testosterones are high. Mild elevations are often due to PCOS, but high levels may be due to ovarian or adrenal gland tumors. Okay. MRI of brain to check the pituitary. We need to do the MRI because in MRI, soft tissues are seen very properly. Okay. Required to elevate the pituitary region in patients suspected to have amenorrhea due to a mass effect prolactinoma. Hysteroscopy. We introduce a scope, okay, to the vagina, and we need to just look all the uterus. Okay, so to look for the endometrial adhesions, that is diagnostic for your Asherman's syndrome. We need to do hysteroscopy. All right, that's it for today. It was a long case. We will meet once again with a new case and with a new explanation. Thank you. Please do like, share, and subscribe my channel. Stay safe. Goodbye.